I just wanted to talk a little bit first about how I came to narrative medicine, because it involves my history with brain injury, my personal history. I didn't get my degree in narrative medicine. I don't have a degree in literature. I came to narrative medicine very organically. And how I came to narrative medicine is about 20 years ago now. It's hard to believe it's that long, but about 20 years ago, my son Neil was hit by a drunk driver in a crash that left him with a traumatic brain injury and killed his girlfriend. Now, I have always been a writer in that I have always journaled since I was young and for all of my adult life. And writing was really my saving grace during that time. That time was a very horrific time for my family, needless to say. And my daily writing practice really saved me during that time. And what I mean by that is I desperately wanted to grieve for all that Neil had lost. He lost a year of high school, a year of college. What should have been the time of his life was spent relearning to walk, grieving for his own grief for his girlfriend. He suffers from anxiety and depression to this day. But I didn't feel like I had the right to grieve because he was alive. And I felt that I should just be grateful for that, right? So the page was really the only place I had to kind of process those feelings. I eventually wrote a book about the experience. And people always ask me, was it cathartic writing a book? And I know Freud, we'll talk about in a little while, believed early on in the power of writing, and how he believed writing helped people was it got rid of those negative feelings. It took them out of the body and onto the page, and it kind of ridded the body of this negative experience. Whereas I felt a little bit differently about it. I felt it was very empowering, actually. And I'll give you an example. In all 280 whatever pages of the book, I never mentioned the drunk driver by name. That was a deliberate decision on my part. I felt that that by naming him gave him a humanity that I did not feel he deserved at that point. And that was very empowering for me. I had a power over him that I would not have had if I were not a writer. So I used the page to process this disenfranchised grief that I had initially. And I used the book as a very empowering experience for me. We can't necessarily change our experience, but we can change our perspective. I did a lot of public speaking through the Brain Injury Association. I became an ambassador. I found my tribe with these people, and they graciously allowed me to be an ambassador. And I spoke to business leaders and high school students and college students and fellow physicians about brain injury and trying to put a human face on what can be a very invisible injury in some cases. And I also found that experience very therapeutic. It was therapeutic for me to tell my story, but at these events, afterwards, people would come up to me and tell me their own stories about the time that their lives changed in an instant. And in hearing those stories, I felt like we were not alone, like we had each other. I went on to write a book, a Chicken Soup for the Soul book, about brain injury. called Hope, Healing, and Hard Work, Recovering from Traumatic Brain Injuries. And some people here in this conference contributed to that book, and I'm very grateful as their editor. And though some of those contributors shared with me how deeply personal and deeply therapeutic it was for them to write about their experiences as survivors, as family members, as caregivers. And so through all of those experiences, through brain injury and through writing, I came to this deeply held belief that through story, we can foster resilience. Through story, we can foster community. And through a shared narrative, we have a shared humanity. So it was about that same time, about 20 years ago, the same time that Neil was suffering from his traumatic brain injury, was about the time that Rita Sharon, C-H-A-R-O-N, you'll hear her name from me a number of times this afternoon. It was around that time that Rita Sharon was first coining the phrase narrative medicine. And she is, to this day, the chief of the Department of Narrative Medicine at Columbia University School of Medicine. Columbia remains the mecca of narrative medicine. She literally wrote the book on narrative medicine called Honoring the Stories of Illness. And so that's kind of one of those memes like on Facebook, how it started and how it's going. So how it started 20 years ago was with my son's brain injury, Rita Sharon's adoption of narrative medicine as a distinct modality. And here we are today with me teaching a workshop. So in terms of the learning objectives, you saw these in your packets or handouts, but just to go over, we will be, or you will be able to describe the basic tenets of narrative medicine at the end of this conference. You'll be able to understand the process of a close reading of a literary work, specifically of a poem, because we're going to be doing that today in just a short period of time. And you'll come to understand how that exercise of closely reading poetry enhances our clinical acumen. You will be able to explain how reflective writing relates to our ability to fully engage with our patients, to actively empathize with our patients, because we will also be doing a reflective writing exercise together in just a little while. And you'll be able to identify how sharing our work, sharing our words, both the content that we write, as well as the process, how it feels for us to be writing, allows for a deeper understanding of both ourselves and each other as colleagues in this room. So what is narrative medicine? Let's start with a simple definition. Rita Sharon talks about how the practice of narrative medicine isn't necessarily its own distinct practice, but a way of practicing. It's any clinical practice which centers a patient's story as its centerpiece. And that clinical practice, I mean, she talks largely about medical practice, but it can be nursing practice, it can be physical therapy practice, speech therapy practice, any practice that is fortified by narrative competence, which we're going to cultivate today. The capacity to recognize patient stories, absorb and metabolize patient stories, and be moved by stories of illness. And when you think about it, before we had all our fancy MRIs and PET scans and genetic testing, we really just had story. We really just had what our patients tell us. You know, there's even a statistic you hear thrown around that about 85% of the time a doctor has made the diagnosis, or at least a differential diagnosis, just by listening to the patient's stories. And then we, you know, confirm what we think is going on with our physical exam, and then we confirm with our testing what we think we felt or heard on our physical exam, but it all begins with stories. And at the end of life, that's all we have still to this day, right? When the chemo doesn't work or the organ isn't there for a transplant, whatever, story is what we have. So let's take it apart a little bit and talk about the components of a narrative medicine practice. And the components are attention and representation and affiliation. And we're going to talk about each of them separately. So when we talk about attention in narrative medicine, we're talking about being present in the room with our client, with our patient. And this has always been a struggle, right? For clinicians of any ilk, right? There's always constrictions, there's always distractions in the room. Time probably being the biggest constraint. We're only given a limited amount of time to see patients. I mean, even myself in my practice, I'm in private practice, I can give myself as much time as I want with a patient, and I do give myself a lot more time than is typical. But even then, the patient may not bring up his or her deepest fear until the very end, when they're literally going out the door. So time is a constraint. The medical record, the electronic medical record, has always been a big constraint, distraction to patients. They hear us clicking and clacking around with our computer, or even before the electronic medical record, or see us scratching with our pad and paper. So we've tried to get that distraction out of the way, and we have scribes in the room and they can hear them clicking and clacking on the computer. So we have chaperones. There's always been a distraction. There's always been constraints, and this has always been a challenge to be mindful. You know, we have a lot to learn from Buddhism in narrative medicine, being mindful. Rita Sharon talks about physicians or clinicians being receiving vessels, and she doesn't mean just being a passive receptacle for these stories, but being an active, engaged listener. And I think we also need to be humble. We need to bring to our clinical practice a humility, which is a challenge as well, right? Because we've gone to school for a long time to bring our expertise. We know a lot about, you know, neuroscience and about gait training and vestibular training and trauma. We bring a lot to the table, but we have to humbly remember that the patient brings his or her expertise on themselves, right? They know themselves, and we need to listen to what they're saying to us, the story that they're telling. And through this all, we're bearing witness. We're bearing witness to our patients' suffering, to the lives they live, to the stories they tell. And that's our greatest gift, to say, I hear you, I see you. So how do we get there? Well, how do we develop those muscles of being present? How do we practice bringing attention to our work, to our office, to our encounters with our patients? How do we get good at that? And narrative medicine has a very distinct take on this, and it is through humanities. We believe that by closely reading literary works, whether that's short stories or essays or poetry, that will afford us the tools we need to become close observers of the human condition and of our patients specifically. So when we read a short story, and there is that evidence out there that people who read fiction, people who read novels are more empathetic people. And we kind of, in narrative medicine, take that to another level and really cultivate that skill of close reading. So we read the content, of course. We read the words, of course. This is an author trying to relate something that has happened to him or her, or to his or her fictional character. But we also listen to the particular voice with which the author is speaking. Is it an active voice? I did this, I did that. Or it's happened to me. And listening for that closely can be helpful with patients, because an active voice implies, and again, we have to be careful about not interpreting too much, but implies an agency, a person in charge, whereas a passive voice, things happen to me, implies more, perhaps, a lack of control or a feeling of helplessness, perhaps. We're going to be talking about the mood of the piece or the tone of the piece. By that I mean, what is my mood when I read this piece? What is the mood that I am left with in reading this poem? And how did the poet make me feel that way? It could be the words themselves. It could be a very uplifting story or a very tragic story. Or the writer could use various literary devices to get across a particular mood. And so we'll be talking about that. Weather is one in particular. The dark and stormy night, to get across this feeling of mystery or fear. Wind, suggesting an agitation. But it can be how the structure of the story, like sort of short, choppy sentences can give that sense of urgency, perhaps. So we'll be noticing that as well. And tone is closely related to mood. It's a term borrowed from music. And we'll be looking at tone and how the tone of the piece can match the words of the piece. They can enhance the words of the piece, or they can contradict the words of the piece, much as our patients' tone with which they are relaying a story can be out of sync with the words that they're using to tell us the story. And the more we can be in tune with that and be aware of that, the more we can, again, not necessarily interpret what that means, but point it out to the patient and just be aware of it. And we'll be looking at structure. We'll be looking at how the words are laid out on the page. Where are the white spaces? Where are the pauses? Because again, when we're listening to patient stories, we'll be listening for those pauses, for what is said, but what is not said, what is maybe implied. And again, not to interpret what that pause means, but maybe just to notice it, take note, and comment. Mr. Jones, you got kind of quiet there. What's going on? What else is there? You know? And then my favorite metaphor, which is I guess a literary stand-in is a way to think about it. An image that works to represent something larger, maybe more ethereal or more universal. I'll give you an example from my own book. I use the image of the crack in the glass of the windshield of the drunk driver as a metaphor for dividing lines. And I kind of weave that metaphor throughout the story, the dividing line between life before and life after brain injury, as you all are very well aware. I had other dividing lines between my life as a physician in charge of the situation and being a mother very much not in charge of the situation. And then physical lines, physical barriers between my son and myself, the glass in the triage window, the glass in the ambulance window. So we'll be looking at metaphor when we read poetry. The writer Orson Card said metaphor has a way of holding the most truth in the least space. And that can be true of our patients as well. When our patients tell us it hurts, right? We still have to rule that out, right? We still have to test for that. But it can be just grief or longing or sorrow, and we have to be able and willing to tear that apart. So we're going to read a poem right now. Is everybody with me and okay so far? Okay. So this is a poem by Pablo Neruda, who is a Chilean poet. Sorry, guys. Who's a Chilean poet and or was, I guess, he died in 1973 at the age of 69. So I'm going to read this poem, and keep in mind the things that we talked about, the voice and the mood and the look for metaphors. And I have some questions that we can start with, or we can just have a free-flowing discussion for a little bit. So we're going to practice close reading of this literary work. To whoever is not listening to the sea this Friday morning, to whoever is cooped up in office or house, factory or woman, or street or mine, or harsh prison cell, to him I come, and without speaking or looking, I arrive and open the door of his prison, and a vibration starts up, vague and insistent. A great fragment of thunder sets in motion the rumble of the planet and the foam. The raucous rivers of the ocean flood. The star vibrates swiftly in its corona, and the sea is beating, dying, and continuing. So, drawn on by my destiny, I ceaselessly must listen to and keep the sea's lamenting in my awareness. I must feel the crash of the hard water and gather it up in a perpetual cup, so that wherever those in prison may be, wherever they suffer the autumn's castigation, I may be there with an errant wave. I may move, passing through windows, and hearing me, eyes will glance upward, saying, how can I reach the sea? And I shall broadcast, saying nothing, the starry echo of the wave, a breaking up of foam and quicksand, a rustling of salt withdrawing, the gray cry of the seabirds on the coast. And so through me, freedom and the sea will make their answer to the shuttered heart. So for the next few minutes, we're going to discuss Neruda's poem. And here's where I'm going to need to ask Janet and Scott to help me monitor the chat or monitor the virtual hands going up. And I have some, some framing kind of questions to get us started, but I'll first just open it up and see if anybody wants to just share something that jumped out at them, something that moved them or confused you or resonated with you. So why did I choose this poem, right? Why, out of all the poems I could pick? And I agree with you. I think that's part of it too, is that we all have an obligation or a calling. And I think sometimes it's so hard to kind of remember that when we're seeing however many patients we see a day, and it's, it's difficult and we're running late and we can't give them all the time that we want, and that people are pulling us in all directions. It's hard to kind of go back and remember what drew us to our profession in the first place. And that's kind of one thing I wanted to bring out and bring us back to, is our sense of vocation, our sense of calling. Narrative medicine, when we talked at the beginning, we talked about attention, representation, and affiliation. So representation, as a writer, is near and dear to my heart. This is where we express our thoughts and feelings, and where we reflect on, in this case today, on this poem, or our experience together with each other. I thought there was a lot of great connection between us, between the words that we were saying, and between us and the poetry. And when we think of expression, we are taking something inside and bringing it out into the light to examine, out into the open. Whether it's our thoughts, whether it's our feelings, you can express juice from a piece of fruit, you can express milk from a breast, you can express pus from a wound, but it's all taking something inside and bringing it out. And sometimes it's beautiful, and sometimes it's not so beautiful. Sometimes it feels good to express something, and sometimes it's a little bit painful. But it's always beneficial, right? And the benefits of reflective writing are replete. The scientific literature is, there are multitudes of studies looking at the benefits of writing for the person doing the writing, whether that is asthmatics. They've looked at having people with chronic obstructive pulmonary disease or asthma, constrictive lung disease, write for 15 minutes for 4 days in a row. And they do pulmonary function studies, and there's measurable improvement. Wound healing, it sounds weird, but they create wounds. They do time-lapse photography. They look at healing process, and it is faster. Wounds heal faster and better and more completely in patients who write. There's some more subjective studies, people with arthritis looking at pain scales, and their pain is improved after a writing exercise. So lots and lots of examples of writing helping patients. Now, we're not patients, we're providers, and we'll get into how that helps. How are our patients helped by us writing? But first, just talking about the mental health benefits. I believe there are some mental health providers in the audience. And one modality of helping patients with childhood traumas, with PTSD, to process their trauma is through a trauma narrative, through someone actually writing down the specifics of their trauma. And after that, what's done with that, it varies according to the practitioner. But one thing that can be done is the patients just reading this, just sharing this over and over with their provider, with their mental health specialist, their counselor, with their families. And it can lose its power over us in that way. In the same way we talked about a little bit, the studies with prisoners doing writings, those kinds of experiences that can be constricting, can be less so if we bring our own perspective to it. Control the narrative is a phrase we hear a lot, but that's kind of what we're getting at here. And narrative medicine adds a little bit of a reciprocity to it, in that there are studies that show that physicians who do reflective writing have more empathy, are more empathic practitioners. And there are studies looking at patients who view their clinicians as more empathic, have better healthcare outcomes, whether that is a lower hemoglobin A1C, better, by that I mean better diabetes control, whether that is a improved lipid profile. So that study is sort of indirectly, reading closely the literature, reflective writing, increasing empathy, improving patient outcomes. And also, if we're writing to, like today, we'll be writing about the poem and our experience together in reading the poem. But if we're writing about, writing is also a way to process difficult patient encounters. And if we're writing for that reason, we're doing that kind of reflection. The patient benefits, not that we're sharing our work with the patient, obviously, but just feeling heard and feeling seen by having someone take the time to think about and reflect on their words and their experience. Bearing witness, basically, we're bearing witness to our patients. So with that in mind, we're going to take, let me just check the time. So with that in mind, we're going to take the time now to do a little bit of reflective writing. To write in the shadow of the art is how Rita Sharon puts it. We have read this lovely poetry. We've expressed ourselves and I think there was some really nice riffing off each other's comments and ideas and perceptions. So I really felt there was some strong work together, even though we're not in the same room. So I'd like us to take about 15 minutes or 10 or 15 minutes, and then we'll have time for sharing and some questions. And we're going to write. I have 2 writing prompts here that I've created, which you can use or not. The first one, I'm putting you in the position of the person with the constricted viewpoint, I guess we'll say, as Eric put it, or the prisoner, as Neruda put it. Pretend you are the prisoner to whom Neruda is speaking. How would you receive the gifts being given? Do you even see them right away? Do they nourish you? How do they nourish you? That's one prompt. In the second prompt, I'm asking you to be the poet, or to be yourself as the caregiver. And what is in your perpetual cup? What do you bring to the people to whom you minister? Or what would you like to bring? And you can use both of them. You can use neither of them. You can just simply write about the poem itself, and how that whole process made you feel, what it brought up for you, what resonated with you about it. Sharing brings up the third pillar of narrative medicine, and that is affiliation. Affiliation is a big goal of narrative medicine, and we've talked about creating that affiliation between client and clinician, between doctor and patient. It goes back to between writer and reader, and speaker and listener that we talked about very early on today. And another goal of narrative medicine is affiliation among colleagues. If we're sharing our thoughts and feelings, making ourselves vulnerable, that is certainly a way to get to know each other on a deeper level. And affiliation extends inward as well, by making connections between our various selves. We may, by that I mean, we may uncover a darker side of ourselves that we didn't know was there, or we weren't particularly in touch with, or a playful side. You know, we may want to be the stern, serious, physician or whatever, and maybe there's a playful side that comes out. And I think if the self is what we bring to the patient encounter, the more we can get to know our own self, the better gift we can bring to that encounter. So in that spirit, if anyone wants to share, they can share either the words, the actual words that they've written, or they can share what that process was like. And in making this and keeping this a safe space in which to share, I will just say, we won't use names if you can help that. And when I do workshops with the residents, I say, this is the Las Vegas of your residency. What is said in the workshop stays in the workshop. So that's the same for us today. This is the Las Vegas of your conference today. What is said in the workshop stays in the workshop. And in that way, I hope this is a safe space. So if anybody wants to share, we have a few minutes for that, and then a few minutes for Q&A. That's the point. We can't always fix everything, right? We have all this expertise, we try, but sometimes just the listening is actually what someone needs the most when there is, while we're trying to figure out the solution together, there is the listening, there is the hearing, the feeling seen,